Hello everyone, this is a video on obstetric magnesium sulfate orders, and this video is for doctors, pharmacists and nurses. It's an order set that is sometimes used at the hospital for delivering mothers for treating eclampsia or preeclampsia, which can cause the death of the mother or the baby if not treated. So please don't forget to subscribe to the channel. So what are preeclampsia and eclampsia? The very basics of preeclampsia and eclampsia. Preeclampsia and eclampsia are diseases of the pregnancy that involve the development or worsening of high blood pressure during the second half of pregnancy. Preeclampsia may develop into the more severe condition called eclampsia. Eclampsia includes symptoms of preeclampsia along with seizures. This condition, when they develop, occur after 20 weeks of pregnancy. They also may develop shortly after delivery. High blood pressure is dangerous during pregnancy because it may interfere with the placenta's ability to deliver oxygen and nutrition to the fetus. The baby may be born weighing less than normal, may have other health problems, or may need to be delivered early. If the blood pressure continues to climb higher, the kidneys may have trouble functioning, and the pregnant or delivering mother may have changes in the makeup of the blood, such as destruction of red blood cells causing anemia, as well as disturbed liver function and decreased platelets. Too few platelets can increase the risk of bleeding uncontrollably during delivery or even spontaneously. In addition, the high blood pressure may cause the placenta to begin to separate from the wall of the uterus, called a placental abruption. This can cause severe bleeding and even death of the fetus and possibly the mother. In the lexicon, you can find the dosing of magnesium sulfate for eclampsia or preeclampsia with severe features, seizure prophylaxis and treatment. There is an IV dosing and an IM dosing. The IV dosing is the one that is normally used at the hospital. The IM dosing is only when there is no IV access. The IM dosing is initial 10 gram loading dose administered as 5 gram in each buttock at onset of labor or induction or cesarean delivery, followed by 5 gram every 4 hours for at least 24 hours after delivery. Close monitoring, including kidney function, example urine output, respiration and patellar reflexes, is required. Monitoring of magnesium levels is recommended for patients with kidney impairment and in patients with signs of toxicity or seizures. Adjust dose to avoid maternal toxicity. Calcium gluconate should be available for treating severe magnesium toxicity. And the IV dosing is initial 4 to 6 gram loading dose over 15 to 30 minutes at onset of labor or induction or cesarean delivery, followed by 1 to 2 gram per hour continuous infusion for at least 24 hours after delivery. Maximum infusion rate 3 gram per hour. If seizure occurs while receiving magnesium, an additional bolus of 2 to 4 gram may be administered over greater than or equal to 5 minutes with frequent monitoring of toxicity. Here you can see an example of the obstetric magnesium sulfate orders. There will be an order for IV fluid for IV access, As a precaution, before initiating the magnesium bolus dose, confirm via 2 RNs, registered nurses, the correct patient, drug concentration, bolus dose, infusion rate, pump settings, line attachment, and labeling of the IV fluid bag as well as IV tubing near the pump itself. After the bolus dose has infused, confirm the maintenance dose, infusion rate, and pump settings via 2 registered nurses. Monitor continuously with RN at bedside during bolus dose administration. So you can see that 4 grams or 6 grams of magnesium sulfate loading dose, whichever one the doctor orders, to be given over 20 minutes, and this IV piggyback can be made in 50 ml or 100 ml. And then the maintenance infusion is given from a separate bag of 20 gram of magnesium sulfate in 500 ml of water, and this is made separately specifically for this purpose by the manufacturer, and the doctor will order the maintenance magnesium dose either 1 gram or 2 grams per hour via pump, and the patient should have an order for calcium gluconate 10% solution 10 ml IV push slowly over 2 to 3 minutes for emergency reversal of cardiac and or respiratory depression as a result of magnesium sulfate. This will be an standby order if it is needed for the patient, only to be used in that scenario. So a protocol like this can help saving the life of a delivering mother and or the baby, and it is to be used only at the discretion of the physician if only the physician considered it is necessary. I hope you will find this video important, and if you like it and if you want to get more videos like this in future, please subscribe to the channel. Thank you.